Hello, everybody, and welcome to our PrecisCa tumor board on multiple myeloma. Very excited about these cases and our panel. I'm Dan Pollier from the University of Colorado, and I'm joined by a really great group of colleagues here today to discuss these cases. And so each of us is going to introduce ourselves, starting with Dr. David Schuster.
Hi, I'm David Schuster. I am a radiologist and nuclear medicine physician from Emory University.
Hi, I'm Dr. Peter Forsberg. I'm a medical oncologist with a specialty in multiple myeloma at the University of Colorado.
Hi, my name is Ajay Nuka. I'm an associate professor at the Emory University Winship Cancer Institute. I specialize in multiple myeloma.
So this is a 65-year-old Caucasian female with an RISS stage 3 IgG kappa multiple myeloma, who maintained a very good partial response on maintenance lenalidomide for 1 year after autologous stem cell transplant, but then unfortunately developed a solitary extramedullary plasmacytoma of the skull. So the question here is, how do we approach a patient with a systemic remission of the multiple myeloma after an auto transplant who develops an isolated solitary extramedullary focus of disease? So more detail on this patient. This patient is acutely presenting with an enlarging lesion of the forehead, not painful and not associated with any other neurologic symptoms. The ECOG here is 0. Medical history for this patient is obesity, no relevant social or family history. And as far as the oncology history, in November 2019, the patient presents with back pain and fatigue, hypercalcemia, acute renal failure, and that led to the diagnosis of IgG kappa multiple myeloma. The imaging shows diffuse lytic lesions throughout the spine, and a bone marrow biopsy shows 70% kappa-restricted plasma cells. Cytogenetics reveal deletion 1p, trisomy 11, and monosomy 20. This patient undergoes 6 cycles of therapy with lenalidomide, bortezomib, and dexamethasone and has a very good partial response. This is followed up in May 2020 with an autologous stem cell transplant using high-dose melphalan conditioning. And a day 100 bone marrow biopsy confirms a very good partial response is ongoing. In August 2020, the patient goes on to maintenance lenalidomide, and that's what brings us to the issue we spoke about at the beginning, this forehead lesion. And, as far as the systemic myeloma panel shows, there's no evidence of active disease, with the typical workup. And so I'd like to just go ahead and ask Dr. Schuster to take a look at the MRI for us and give us his thoughts on that.
So here we have both a sagittal and axial images from an MR with gadolinium enhancement, showing enhancement of this left frontal lesion, which is coming from the scalp, and it looks like it is eroding into the skull and through the skull. And then you also noted that this patient had an FDG PET, which showed no other active lesion. And I think that's very appropriate at this point, as FDG is especially excellent for extraosseous disease.
Okay, very good. So I'm going to go back there after that. And yes, as you suggested, the PET showed no evidence of systemic disease. Lumbar puncture showed no leptomeningeal involvement. Bone marrow biopsy showed no monotypic plasma cells or B cells. The SPEP showed a monoclonal protein of 0.1, faint monoclonal gammopathy, IgG kappa, kappa lambda ratio of 1.1. The scalp was biopsied, and it did show plasma cell dyscrasia with sheets of monotypic plasma cells that are positive for CD38, CD138, MUM1, kappa light chain restriction, and the Chi67 was 35%. So first of all, I just want to sense, Dr. Forsberg, how common is this scenario where you have a very focal relapse of this disease without any other systemic areas of disease involved?
So it happens. I guess I'd say that it's, while it's not, I don't have an exact, percentages or prevalences of how, relapse that's characterized specifically by isolated focuses of disease. It's certainly something that we see from time to time, with disease emerging in single locations. I think that there are, characteristics of that we may want to, make sure we understand. We talked about the importance of a PET scan. I think you really want to make sure you have sufficiently staged the patient to know that they don't have multifocal disease, that they don't have a emerging marrow involvement or other foci of disease on high resolution full body imaging to make sure that it is something like a unifocal relapse. Because I think that it's certainly something we see, and the time course is different patient to patient. Sometimes we see these isolated areas emerge years after a stem cell transplant in a very stable remission, versus this patient who's developed this disease a little bit more close to her initial treatment than some patients. So even in patients who have this, sort of unique pattern of relapse, there are different features of it, extramedullary versus medullary, short time course to something emerging versus a longer latency period that may have some, future impact. But I do think it is something we see from time to time in patients who sustain systemic remission but have isolated focuses of disease recurrence.
Great, thanks. And Dr. Nuka, how do you approach a situation like this?
This is a lady that really is. I'm feeling sorry for the case. She relapsed 4 months after the transplant. So this case really highlights the need for the initial PET scans. So the way that I always look for a case like this is like, does the initial PET scan show any evidence of extramedullary disease? If there is evidence of extramedullary disease there, like she got a good response to RVD, she got a good response to transplant, now she was placed on Revlimid, now she's already showing signs of relapse with extramedullary disease. So treat her systematically. So systemic treatment is what she needs. Number two, so we're also missing the concept of what exactly is happening. So bone marrow is a niche where the plasma cells should be there, and they're secreting these antibodies. Abnormal plasma cells are making the abnormal antibodies, and we're using the marker the M protein as a marker, or any of the serological markers as a markers of the disease. So we're clearly relying on the secretory potential of these plasma cells. Now, in her case, think about these plasma cells as non-secretory. So she has a systemic relapse, and the plasma cells are not secreting. And we're relying on looking at one compartment and saying that she's in systemic remission and she has an isolated focus of relapse. Not the right way to treat. She should be treated again like systemic relapse. So there are lots of holes in the picture or the case, only for one reason. This is one of the clear examples of where I feel a proper workup needs to happen at the time of diagnosis, so that we have the right response or right answer right at this case, a year after her diagnosis, 4 months after a transplant, dealing with a situation that we don't know what to do with.
Great. And specific therapy that you would use, you said you would recommend a systemic treatment. Would you give any recommendations as to what that might be in this case?
Absolutely. So she does not have any neurological symptoms. She does not have any mass effect. She just has an enlarging mass. So it does not need any local treatments at this point of time in terms of radiation. I'll put that in the back burner. Bring the best, most effective systemic treatment right to her. She got RVD at the first remission. If she's eligible for a clinical trial, that's probably where I would go with the most effective treatment. And in the scenario, like most clinical trials do, they don't accept the patients who do not have any measurable disease, so which she's exactly a part of. So she goes to the most effective treatment in the early lines of treatment, using a CD38 monoclonal antibody, whether it could be daratumumab or isatuximab, using a potent immunomodulatory agent like pomalidomide and a steroid with dexamethasone.
Great. So I think in summary, a case such as this, first of all, I think the quick relapse after an autologous stem cell transplant is concerning. I think what we learned is that focal relapses can happen in multiple myeloma, and if they aren't overtly symptomatic, they should be addressed systemically. In this case, with a CD138 targeting antibody, an immunomodulatory agent, and steroid approach.